So this is a presentation for rhabdomyolysis for the Pathophysiology class in the MSN program at West Texas A&M. A little bit about myself. My name is Matthew Bassett. I am a BSN RN and Progressive Care certified, and I currently work on a progressive care unit at University Medical Center in Lubbock, Texas. I chose this topic because I have not personally taken care of a patient with rhabdomyolysis before. I have had many patients that could possibly progress to rhabdomyolysis, but I really just have never taken care of someone who's officially been diagnosed with it, but I would like to have the knowledge in case I get one in the future. So what is rhabdomyolysis? It is defined as the rapid breakdown of muscles that causes the release of myocyte intracellular contents into the bloodstream and extracellular space. There are many different causes for this that we will go over, namely seizures is a cause of rhabdomyolysis, prescription or illicit drug use, so your meth, heroin, or cocaine, and also prescription drug use such as atorvastatin or rosuvastatin, namely the statins. Those can cause rhabdomyolysis as well, just as a side effect of the medicine. Other causes include overworking the body, such as in working out or lifting weights, severe bodily injury, such as in a car wreck or just any severe injury that can affect your muscles and damage them severely, and also prolonged immobilization, because the muscle wasting can cause rhabdomyolysis to occur. Therefore, you need to watch out for that in patients in nursing homes or just people who have a condition that causes them to sit still for too long. Moving on to the pathophysiology of rhabdomyolysis. So as we discussed before, injury occurs to the muscle and causes muscle cell damage, and then the ATP in your muscles ceases to work properly, so that causes a large buildup of calcium and potassium in the muscle cells, and this occurs until the cells lyse or basically explode and start the rhabdomyolysis process. When all these toxins and all these myocytes and creatine kinase, which is a byproduct of the muscle cell lysis, reach the kidneys, this can cause buildup in the renal tubules, which can also instigate the ROS system. And as we know, ROS is the conversion of angiotensin 1 to angiotensin 2, which ultimately causes fluid retention and increased blood pressure. But this is an issue when this happens because it's a protective mechanism of the body. But when this happens in your body, it can lead to renal hypoperfusion, as we see up here, because of the vasoconstriction, and it leads to your kidneys not getting as much perfusion as they need to, thus causing kidney damage. Whenever those cells lyse, obviously potassium is leaked out into the cells. Also phosphate, extracellular phosphate will increase, causing hyperphosphatemia, and this can lead to them binding with the calcium, because as we know, phosphate and calcium bind together, and this can lead to a bunch of issues like initial hypercalcemia when the cells lyse, and then hypocalcemia as the phosphate binds to the potassium, and increased levels of phosphate just because of the muscle cell wasting. The pathophysiology of statin use, however, is slightly different mechanism, but it ends in the same goal. Based on certain articles and studies on this topic, genetic predisposition and something called isoprenoid depletion leads to muscle fiber apoptosis. Basically, that isoprenoid is a type of lipid, and that's what the statins actively use to break down. And in some people, whenever that isoprenoid decreases, then they can be genetically predisposed to going into rhabdomyolysis because of statin use. Moving on to risk factors. Risk factors, as we talked about before, are seizure disorder, because that tensing of the muscles can cause muscle pain, and rhabdomyolysis. And studies have also shown that the levetiracetam or Keppra used for seizure control can also instigate rhabdomyolysis as well. Genetics and use of statins we've already gone over quadriplegia, because that can lead to prolonged exertion, and the mechanism of action for the quadriplegia can also lead to muscle cell damage. Overexertion we have not discussed yet, but you see this a lot in CrossFitters and power lifters, just that work entirely too hard and put their muscles under too much strain. This can cause rhabdomyolysis and be just because of the sheer strain of the muscles. And there have been many cases of rhabdomyolysis that have been caused by either a regular person jumping into a workout too quick, or someone who lifts weights a lot just trying to push themselves too hard. Another interesting cause and risk factor is COVID-19. And basically this can, if you're predisposed to infections, but also if you just get infections in general, the COVID-19 causes the immune response, which can cause inflammation of muscle cells, which can therefore lead to their muscle breakdown, leading to rhabdomyolysis. Clinical manifestations of rhabdomyolysis. There is a triad of symptoms talked about by the guys Bai and Dimachki in an article they did in 2022. Those triad of symptoms will be muscle pain, muscle weakness, and dark urine. Mainly all you'll see is the dark urine in many cases because there are high levels of creatinine kinase and myoglobin present in the kidneys and thus excreted in the urine. You will see some muscle pain and some muscle weakness at times because the muscle wasting causes the muscle wasting and muscle breakdown can cause that pain and weakness. As you can see here, this full triad is only present in 1 to 10% of cases, so you won't see this a whole lot. Electrolyte imbalances can occur, as we talked about before: potassium, hyperkalemia, calcium, hypocalcemia, and then hypercalcemia, and then hypocalcemia again. Phosphate, hyperphosphatemia. Namely, those potassium and calcium, when they get all out of whack, calcium acts in muscle contraction, so that can lead to your heart muscle getting affected, which leads to cardiac dysrhythmias. And then potassium and hyperkalemia. When hyperkalemia happens, as many of us know, that can cause cardiac dysrhythmias as well. And so pretty much that's something you got to watch out for. So rhabdomyolysis is not something you just let happen. You've got to make sure that you address all the issues, because it can lead to cardiac events. As for diagnostics and labs, the number one main diagnostic that you'll use to diagnose rhabdomyolysis will be a urinalysis. In this urinalysis, you'll most likely find increased creatinine kinase and the myoglobin. And because those are byproducts of the muscle wasting, so those are just common markers that you'll find. Serum creatinine kinase is another good one to draw, just because the damaged and dying muscle cells will release large amounts of this, and it'll be in the bloodstream before it reaches the kidneys. And then other diagnostic methods depend on the cause, so you can draw blood cultures if you're concerned about an infection causing it. Serum tests will also include electrolytes or alcohol electrolyte serum levels, just because it'll throw your electrolytes all out of whack. And then alcohol level, if alcohol toxicity is suspected, because that's another possible cause of it. And namely, when your kidneys get affected, the arterial blood gas, you can use that as well to measure for metabolic acidosis, which if you don't address that, that can become potentially lethal as well. So official diagnosis would happen if you have a causative factor such as trauma, overexertion, overheating, infection, any of the other causes listed up here, and then one or more of the triad of symptoms, and but the most common thing that you'll see is increased creatinine kinase in the urine. So that's usually how it is diagnosed. So once it's diagnosed, then you begin to treat the rhabdomyolysis. This can be done by aggressive fluid resuscitation, because the main deal is rhabdomyolysis will present, many people with that will present with acute kidney injury. And so obviously whenever someone comes in with an acute kidney injury, you want to give them fluid resuscitation, see if you can get their kidneys to work again and excrete all of the toxins. So this would be done by aggressive IV fluid resuscitation or oral resuscitation as well. Now, if someone waited too long to come in for the rhabdomyolysis, or just some other unnamed issue happened, they might need hemodialysis. This could also be necessary if their electrolytes are all out of whack and the patient is symptomatic. So hemodialysis might be necessary, but it is rare that a patient would need hemodialysis. But mainly, if you take nothing else away from education and resuscitation, maintaining fluid through the kidneys is the key to treat and resolve rhabdomyolysis, because obviously your kidneys can't function without water flowing through them, and you can't excrete any toxins if your kidneys are not working properly. So education you would give to your patients whenever they get discharged would be just, what we did IV initially, encouraging fluid resuscitation, encouraging fluid intake, also encouraging them, if they're a new person to working out or if that was the cause of it, then obviously easing back into their workouts. Don't overexert themselves or don't go train outside when it's 100 degrees. Because those are the two known causes of rhabdomyolysis, and that's when you get a lot of people just with those issues. Another possible cause, and another just, intradisciplinary cause that I can see needing for prevention of rhabdomyolysis due to muscle wasting would be physical therapy for immobile patients. Because I can tell you many times I've seen patients come from nursing homes or just be quadriplegics, and they are very contracted, and they are very much their muscles are just very much wasting away, and they're very thin and malnourished, and they don't move a whole lot. So just encouraging PTs to work right off the bat with passive range of motion for patients who might be a quadriplegic, to prevent muscle wasting as well. Also, obviously, prevent infection, and pretty much just be gentle with everything that could cause muscle damage. And last but not least, if injury is due to medicine, then the doctor would need to be made aware that this happened and it could be due to the medicine. And so if patient's taking a torvastatin and you're the nurse, you might just want to you will want to notify the physician that the patient's had a history of rhabdomyolysis after taking a statin, and therefore the doctor can dose them more carefully. These are my references here, and that concludes my presentation. Thank you for your time.